New York City's new health commissioner, Dr. Ashwin Vasan, is leading his first COVID briefing for the city. Let's go to it now.
And here today by Dr. Mitch Katz, Dr. Celia Quinn, and Dr. Ted Long, joining us through Zoom. Throughout the COVID-19 pandemic, the city has helped New Yorkers stay safe by keeping them informed about how the pandemic was unfolding in our city. You have played and continue to play a vital role in that process. So although it's only my first week on the job, I understand how important regular communication is with all of you. I'd like to start by sharing what we are seeing with COVID-19 and what actions New Yorkers can take to protect themselves. What does the data tell us? Community spread remains low right now based on our New York City alert levels. Hospitalizations and deaths are stable or decreasing. To assess levels of risk, we look at several indicators, not just cases, consistent with CD recommendations. We're keeping a close eye on the numbers and will continue to let you know what they tell us. At the same time, we know the increase in cases in other parts of the world can be worrisome. While the losses of the last 2 years have been profound, we've also developed tools in that period that are saving lives, including testing, prevention, and new treatments like antiviral pills. Treatment at home with antiviral pills is a relatively new tool in the fight against COVID-19. And it's now more widely available, something that was not true at any other point in the pandemic, including the last wave. Treatment usually works best if you begin it soon after you start feeling ill. So get tested right away and call 212-COVID-19 to get treated. The single greatest tool against COVID remains vaccination. That includes boosters, which we know increases immunity and reduces your chances of getting seriously ill. We need all eligible New Yorkers to get their booster as soon as it's their time, and for many of you, that time is now. Boosters are especially important for those at high risk of severe outcomes and those 65 and older, of which only 55% of New Yorkers have received their booster or additional dose in that group. If you have an older adult in your life and they haven't been boosted, I urge you to help them make an appointment today. The city stands ready to assist anyone who needs help with an appointment. If you have questions, please call us again at 212-COVID-19 or visit us at vaccinefinder.nyc.gov. I should add, it's also a good time to visit with your doctor for a regular checkup or any appointments you may have missed during the pandemic. As a primary care doctor and surrounded by primary care doctors, I have seen, and we have seen, how many of our patients have delayed or foregone care throughout the pandemic, leading to new or worsening health issues. The time to reconnect with your healthcare providers is now. So look, it's an honor to be the city's doctor. Something you'll hear me talk about a lot is the emotional toll that this pandemic has taken on all of us. We have all been through so much over these past 2 years, and continuing uncertainty about the future of COVID can certainly add to the strain on New Yorkers' mental health and well-being. I know that the need to focus on mental health is as important as continuing our fight against COVID. Resources and mental health supports are available, including through NYC Well. We must continue to be there for one another and to get through this together. In addition to getting vaccinated, and for those eligible getting boosted, I want to ask every New Yorker to reach out to someone in your life today to check in or just to share a few words of kindness. Let's rebuild those connections that may have broken down over these past 2 years. The small step can make all the difference in that person's life and in yours. So thank you, and with that, we'll take some questions.
Commissioner, you referenced briefly the variants in the surges we might be seeing in other parts of the world. Is there any indication that they're here in New York City? What level of concern should we be feeling now?
Number one, I just want to, sort of empathize and say that I understand New Yorkers' concern, given where we've been over the last 2 years and successive waves, that rising cases in other parts of the world would lead to anxiety. That's completely understandable. Know that, as we have always done, we are tracking these variants very closely. I think you're referring specifically to BA.2, the Omicron subvariant, and its role in rising cases across the world. I think the important thing to remember and to emphasize for New Yorkers is that currently there is no evidence that BA.2 causes more severe illness, increases risk of hospitalization, or that our current vaccines offer less protection against it. But we continue to monitor this, and we continue to stay vigilant.
What benchmarks over what period would need to be met for the employer mandate to fall? And I'm looking for specific benchmarks, not just a generalized answer that you're looking at.
We published a color-coded COVID alert system a couple of weeks ago. And as we showed up earlier on the screen, we're tracking a lot of data, but there are 3 principal data points that are of highest importance to us. That is cases, hospitalization rate, and bed occupancy rate. This is consistent with CDC guidance as well. And right now we remain in a low risk environment, that data taken together. But I do want to emphasize that our mandates have been among the most important life-saving policies that we've put into place throughout this pandemic, and it's helped us build up a wall of immunity, a bulwark against whatever this virus does to change or may throw at us in the future. So I would love for me to sit here and say I can give you a date or a data point when we would lift those things. Right now, we are in a low-risk environment, and we'll continue to evaluate that data.
Do you have any in mind, or it's indefinite?
Any what in mind, sorry?
Level to which you would fall, those 3 metrics or any metrics, when you would rescind the mandate, or at this point you have none? It's indefinite.
I think it's indefinite at this point. I think people who have tried to predict what's going to happen in the future for this pandemic have repeatedly found egg on their face, as they say, and I'm not going to do that here today.
And Commissioner, I'd just add, we have many mandates for vaccinations that are for diseases that are very low, including polio and measles, right? Nobody has suggested that we should, because polio levels are so low, we should, say that school children shouldn't be vaccinated for polio. So I think that vaccine mandates have a long and important history in public health.
Well, not for employment, right?
If you want to be employed at my institutions, yes.
Well, employed anywhere.
But the point is, if you have mandatory childhood vaccinations, then everybody grows up to be vaccinated. So it turns out to be irrelevant, right? The point of childhood vaccinations is by doing it at childhood, you're giving the person maximum benefit, and then they grow up as a whole cohort of people who are fully vaccinated.
Sarah?
Dr. Vasan, could you address the mask situation in schools, whether there's any plan to bring it back if BA.2 gets worse, and also for children who are under 5?
Thanks for the question. Yes, and I'm aware. I'll start with the last question first. We have consistently seen disproportionate hospitalization rates in the under 5 population compared to other childhood groups. And as a father of a 2.5-year-old and 2 other older kids, I want to keep them as safe as possible. I would love nothing more than to send my son to daycare without a mask. But as a scientist and as a doctor and an epidemiologist, I want to keep him safe, especially because he's not eligible for a vaccine. We're always looking at the data. As I've said, we have very clear benchmarks of how we're assessing risk, and we'll keep reevaluating whether that mandate should stay in place, and right now we think it should stay in place.
People are just beginning to adjust to this new normal endemic phase. What would a benchmark be if these variants continue to go up?
I'm going to sound like a broken record, but I think the color-coded risk alert system provides us with very clear benchmarks. As we showed up on the screen, cases, hospitalization rates, and bed occupancy rates remain the pillars of that color-coded system. There's other data that we also take into account. And I think the wonderful thing about that system is that it is useful for New Yorkers to calibrate their own individual decisions and their own behaviors and their own risk. And it's also very important for us as government and as officials to set policy decisions. So when we're talking about lifting or reinstituting particular mandates, we have very clear tiers of risk, and right now we remain in a low-risk environment.
For people who already have the booster shot, is it important to get, or how important is it to get a fourth shot on COVID?
Right. I think there's been a lot in the press about this right now. What we know is that 2 of the manufacturers have submitted requests for approval to the FDA for a 4th dose, one of them specific to certain high-risk groups and one of them for everyone. As with every other vaccination approval, we're going to be following the guidance and the science from our federal colleagues. And what gives me a lot of encouragement is that we have a vaccine delivery system that can get it out to as many people as possible, as quickly as possible.
Okay. I'll take the opportunity, though. What is the messaging on masks? We have two people at the top. I know you're speaking. What is the messaging on that to the general public as they go inside public buildings? What is that messaging like?
I think in a low-risk environment, because we are currently there, we are advising New Yorkers to think about their own individual risk, think about their own individual comfort level, think about their own individual conditions and factors in their own life. Remember, we wear masks not only for ourselves, but for our loved ones, our families, our community. And we interact with a whole host of people. So our choices are really need to be calibrated based on our individual comfort level in a low-risk environment where we have currently lifted mask restrictions in indoor settings.
Doctor, you talk about the fact that BA2 is not more dangerous. How prevalent is it now? And what concerns do you have about potentially rising hospitalization rates?
I'm going to kick it over to my colleague, Dr. Quinn, to provide further detail, but just know that we are tracking this very carefully through our public health laboratory.
Thanks. Yes, I'll just add, we do a lot of sequencing of SARS-CoV-2 in New York City. We are sharing that information on our website on the variant data page. BA.2 is a sublineage of Omicron, and it has been increasing over the past several weeks. We've been seeing that. At the same time, the overall case numbers have been relatively stable, with some increase in the last few days. So, you know, I think what Dr. Vasan was talking about is that we have seen that BA.2 does not appear to cause more severe illness than other strains of Omicron. It may be a little bit more transmissible, and that's why it is increasing in proportion to the other circulating Omicron strains. And so, you know, we'll be watching the cases, hospitalization rates, and its impact on our healthcare system as we look at the alert levels going forward.
How prevalent is it now?
Our most recent data shows that around 30%, and that's also similar to what CDC's data is showing and their prediction for this week for this region.
Just one thing, the initial Omicron strain was not more dangerous, but the hospital patient count went up. So is there a concern the same thing will happen?
I think that what we showed through the Omicron wave, through the work of Dr. Katz, our colleagues at H&H, and throughout our hospital systems, is that our healthcare systems were prepared for those rising cases, that they had adequate supplies and staffing and occupancy. I'll kick it over to Dr. Katz to add more color to this answer, but again, whatever this virus throws at us, I think we're in a much stronger position than we've ever been in the 2 years of living with COVID.
I would just add, Commissioner, that as you described, the availability of the monoclonal antibodies and the antiviral drugs is much better now than it was when we were going through the cycle of Omicron. You'll remember that we had almost none of the monoclonal antibody that actually worked against Omicron, while now we have good supplies of that, and we're able, for anyone who gets COVID, as the Commissioner said, if you call 212 COVID-19, we will be able to connect you either by phone or virtually to an emergency room doctor at health and hospitals. We'll be able to arrange for you to get either the antiviral pills or a infusion of monoclonal antibodies. And so that is a level of protection that we did not have with Omicron in the January.
Can I have a follow-up on that? I'm curious because I spoke to Dr. Varma, who's the senior advisor for former Mayor Bill de Blasio, and he had said some of the testing that's coming up for people who are getting this specific variant, if they're triple vax, they're taking the test, their tests are coming back negative while they have full-blown symptoms, and then once their symptoms are subsiding, that's when the tests are coming back positive. And so I was curious if you're seeing, with the prevalence of so many at-home tests, are you getting data that indicates that people are not feeling well to kind of like shift how you're responding? And then on top of that, like, is there a concern that the current at-home tests that are on the market are maybe not calibrated well enough for a more vaccinated population and for this specific subvariant?
I have not heard that, and in fact, the people that I know, both my patients and family and friends, have all, when they've gotten symptomatic, tested using home tests, and they've been positive, and that's very up to date. So I have not. I mean, every test has mistakes. I mean, every test in medicine has mistakes. There are people we know who are negative for the home tests and are positive when they have PCR, but that's not even necessarily a mistake. That may just be many more viral particles are needed for a positive home test, and so they may not be that contagious. But I have not heard anything about a specific I don't know. I don't want to what use. Yeah. Yeah, my experience was definitely over the last 2 weeks. So
it may be too early to tell, but we do encourage any New Yorker with active symptoms who's testing negative, feel free to go get a confirmatory test. Feel free to go get a PCR. We have plenty of H&H, T2 testing locations still running. Go to your healthcare provider, go get a primary care visit, and get tested through your primary care doctor and reconnected into care.
No, I didn't get to Andre. It's a variation on the question I already asked, but a little more specific. The city health department shows only 36% of the population is boosted. Meanwhile, Moderna and Pfizer are asking for a fourth shot. How much emphasis is New York City putting on making sure people get a boost before the city starts even worrying about a fourth shot?
It's essential that New Yorkers go and get boosted when they're eligible. We know very clearly that getting boosted increases to longer term and higher levels of immunity, reduces the risk of severe illness and hospitalization, and of course, death. And so we're encouraging every New Yorker who's eligible, most especially New Yorkers in high-risk age groups and high-risk groups for other reasons like co-occurring chronic illnesses and immunosuppression, to go get boosted as soon as possible. And we are active out in the public. My colleague, Dr. Morse, is on channels every day talking about how New Yorkers need to get boosted. You'll hear me say the same thing wherever I go. The time to get boosted is as soon as you're eligible, and for many of you, that time is right now. So we have a robust surveillance system in our city. It's made up of data from our emergency departments, from our public health lab, sequencing data from our electronic lab reporting system. It's one of the strongest surveillance systems in the world. And like most surveillance systems, it doesn't capture every test taken in the city and doesn't need to in order to assess the level of the state of the pandemic. Think of it like when you report on rainfall in New York City or snowfall in New York City. We don't report every snowflake. We look at the amount of snowfall in a period in Central Park and in other locations. That's called sentinel surveillance.
Are you concerned at all that people will be using those at-home kits and not reporting positive?
Well, we're encouraging all New Yorkers who test positive at home to call 212 COVID-19 and get treated. And so that is their way of recording that test with our healthcare system. At-home tests are a powerful tool to drive individual decision-making, to drive behaviors. And as you know, the mass distribution of at-home testing has kept our schools open and our children safe. So it is an important tool in the fight against this pandemic to drive individual behavior.
Right, they don't seek treatment as long as individuals feel that they need treatment. Should they still be reporting those results the same way at home?
They can. What I think I'm trying to communicate is that it isn't an essential part of our surveillance system. It is an important public health tool for individuals to make good decisions.
Can I ask a quick data question? What is the under 5 hospitalization rate? We have for everybody 3.4. What is that rate for 100,000 for kids under 5 who can't be vaccinated?
We're happy to follow up on the specifics of the data. I don't have that at hand. Yep.
I actually just want to follow up on my question. I don't think I got an answer. Specifically, how is the city trying to work on collecting data and kind of touch upon this in terms of the prevalence of at-home testing? I know that Dr. Varma and Manhattan Borough President Mark Levine had called on the city to do some sort of like more generalized sampling of like the average city residents, kind of get a better sense. And I was wondering if there's a shift that now that more people are doing at-home tests.
And I'll kick it over to my colleagues if they have any thoughts first. But I think underlying that question is the idea of how can we get the best early warning system possible, right? We want to know what's going to happen with the pandemic as soon as possible. And I'm here to say that our routine surveillance system, made up of the different points that I talked about, is incredibly sensitive at tracking where the pandemic is headed. And so at-home tests, we to date haven't seen at-home tests providing any meaningful value, predictive value, in providing us with a more sensitive early warning capability at this point.
Let me just follow up on Amanda's question. Is there surveillance testing separate from I decide to go take a test? Like, do you have a kind of cross-section of New Yorkers who just randomly test to try to get a sense of what the infection rate versus the positivity rate is?
I'll have Dr. Long jump in as well, but again, our surveillance system is made up of a compilation of data from our electronic lab reporting system, from our emergency department, from healthcare facilities, from sequencing from our public health laboratory. So it's not random in that way. It is people who have gone and gotten tested at those places, and that gives us a really important snapshot of where we are at any point in the pandemic. Any other additional thoughts?
If I could jump in, can you hear me okay?
Yes.
Yes, Ted, we can hear you.
Okay. Great. Now, I appreciate it's a really important question. Just to back up for a second, when we look at percent positivity, which we compare across communities in New York City, we've always only used the PCR test to have one test where we have the positives and the negative values in totality to understand if there are meaningful differences or any early warning signs. On Monday of this week, we did more than 55,000 PCR tests, more than 60,000 tests citywide. So that gives us the line of sight that we need to understand what's going on in terms of if there is a signal of increased transmission anywhere in our city. To be very clear, though, I strongly encourage New Yorkers to use home tests if that's the way to get yourself tested. If you have a home test and you aren't feeling well in the morning, use that home test to know if you have COVID before you go to work, before you go anywhere. So home tests are a tool we didn't have before that we have now, and especially with our new early warning system, our color-coded risk scale, we have abilities to, if we do see risk increasing, rapidly distribute home tests across New York City through community-based organizations, houses of worship, libraries, cultural institutions. It's a new tool that we have now, we didn't have before, that we should use, especially if we've increased risk in our city.
About sequencing, how much sequencing do you do, and how quickly do you pick up new variants?
Yeah, thanks for that question. In the recent weeks, we've done about 10, we've had sequencing results for about 10% of all of the SARS-CoV-2 specimens that are reported to us. That's on our website. The percent that we were able to do was lower in the peak of the Omicron wave because there were so many cases happening, but we still had sequencing data for more than 4,000 results every week. Most of the information that we get about sequencing comes from our public health lab and the pandemic response lab, but we are also getting sequencing results from a few other labs as well that are reporting to us through our electronic lab reporting system. That amount of sequencing is pretty good, and it means that we can pick up and detect new variants within like a week or a few weeks of them emerging here in New York City.
Original Omicron variant, there was less of a loss of taste and smell and more of a scratchy throat symptom. Is there anything unique about this subvariant that people are reporting in cases that are seeing?
Yeah, it's a good question. Thank you for raising it. I think there's some suggestion that this subvariant may be similar to Omicron in some ways, might be more associated with symptoms above the lungs, less respiratory compromise, and more upper respiratory tract, you know, the stuffy nose, the itchy eyes, the runny nose, and so I think there is some suggestion that BA2 is following that same trend, but it's still quite early.
Can I ask one more question? Is attending practice, as Kyrie Irving is doing, in violation of the employer mandate about the second index? Is he allowed to attend practice?
I can follow up with you on what on the various mentions. We're going to have to wrap up now, so
I'll get an answer about Kyrie Irving in practice.
Yeah, I'll get you something like that, or direct you to the right place. All right, thanks everyone. Thanks so much.
Thanks everybody.